Assistant program. Thank you. No, to good guy.
Good afternoon, everybody. Thank you for hanging around to see us on a Saturday afternoon. As you've heard, my name is Dr. Veronica Gillispie-Bell. I serve in several roles. I think what's most pertinent to today, I serve as the medical director of our state perinatal quality collaborative and our pregnancy-associated mortality review. And so what that means is that I lead the committee that reviews all the maternal deaths in the state, and that's defined as the death of an individual at the time of pregnancy up to 1 year at the end of pregnancy. And when we're looking at that data, we're looking not just to see the numbers, but to also understand what's happening with maternal mortality. Many of you probably already know that the United States has the highest maternal mortality of any high-income country. And while the rates have been decreasing across the world, our rates have been increasing. We did have a statistically significant decrease in maternal deaths in the United States between 2022 and 2023. But if you look at that number, it's still not as low as it was in 2018. So are we really improving maternal outcomes? I think the question is still out there. We need more numbers to see. But even with that decrease from 22 to 2023, the rates decreased for every single race except for Black women. So regardless of if we are improving outcomes, we're not improving them for everybody. And so that means that there is more work that we need to do. Specific to Louisiana, the data just came out about 2 weeks ago with the 2023 stats, and Louisiana now has the highest rate of maternal mortality. We were ranked number 5, but we have jumped back up to number 1. So through that process of, like I said, examining these maternal deaths, we know that when we look at our pregnancy-related deaths, or deaths from a condition related to the pregnancy, cardiovascular conditions and cardiomyopathy are our leading causes, and those rates are the highest amongst our Black patients. And so it's really important, I think, that we understand what is driving maternal mortality, but also to understand where we can make a difference. Where are the solutions? I will tell you 100%, it takes each and everybody in this room, no matter what you do in healthcare, to make these improvements. And so we have a panel here that is representing a lot of different entities to hopefully demonstrate that for you all. So I'm going to start with Varsha, because Varsha is going to talk to us more about patient experience. Again, when we think about looking at what's happening with maternal mortality and morbidity, those near misses, it's always important to understand the patient experience. There's so much value in that. And so with that, Varsha, can you tell us a little bit about your pregnancy journey?
Roger.
Yes, thank you, Dr. Gillispie. So I'm grateful to speak to everyone today on this panel about a topic that I'm very passionate about. And I'm an advocate for Connected Moms, which is a maternity online monitoring program that pretty much saved my life. And Dr. Veronica Gillispie-Bell is my OB, Gyne, and she's the one who introduced me to this program. And when a nationally recognized expert, a trailblazer in maternal health, tells you and recommends that you should join this program, you don't tell her no. A little bit of background information about me. I'm a native of New Orleans, a first-generation American. My mother is Jamaican, my father's Filipino, and I practiced here at Ochsner Health in our neurocritical care unit. So I treat a lot of stroke patients, those who have hemorrhagic stroke, ischemic stroke. I treat a lot of patients who have epilepsy and brain aneurysms and tumors. That's important because as a patient, this is a unique perspective for me. As I was in my pregnancy in October 2021, we were excited to welcome our third baby. And so I joined this program, Connected Moms, and with Connected Moms, you're supposed to take your blood pressure every day. Well, throughout the pregnancy, my blood pressure was fine up until the very last week of pregnancy. My systolic blood pressure was 198, almost 200. I started having severe headaches, And it was because of that program, it alerted my providers, Dr. Gillispie and her team, and I was immediately contacted to come into the hospital. I was immediately admitted, I was treated, and they induced pregnancy for me and put me on a magnesium drip, and it was just a lot, and I do believe that being a part of that program really saved my life. Working in neurocritical care, I have seen the other side of it. I've taken care of patients who unfortunately have had poor outcomes postpartum, and their hypertension has led to strokes, hemorrhagic strokes that were just incompatible with life. And it's so hard as a provider to tell a family who is so hopeful to have this new baby that the mother is no longer with us anymore because she's had this hemorrhagic stroke that's incompatible with life. Hemorrhagic stroke is the most common stroke associated with pregnant, or postpartum women who have preeclampsia and eclampsia. And recent data has shown that women ages 15 to 44 who have these pregnancy-associated hemorrhagic strokes, most of them occur postpartum. And for me, being on the Connected Moms program and having a provider like Dr. Gillispie, who I trust and we built this relationship with before I was released from the hospital, she told me, Varsha, you need to continue with the Connected Moms program. And as a new mother, you have this brand new baby that you're bringing home. This was my third child. I was very busy. I didn't have time. I was a working mother, but I still heeded her advice and was taking my blood pressure. After about a week, my blood pressure was still systolic in the 200s. And that program notified her, and she told me to immediately come in. And after I had the baby, I was readmitted back to the hospital for 3 days. So this program really is important because in that postpartum stage where mothers are very busy and oftentimes neglect their own health, it helps us to stay connected with our providers, ensuring that we're well monitored even at that postpartum stage, which is where most deaths occur. And so I'm really grateful and happy that I was a part of this program that saved my life. After that, I saw 2 cardiologists. I was put on 3 blood pressure medications, anoxalytic because I was anxious, an antidepressant. So many things, but it was because of the care of my providers, their care coordination, that really, I do believe, helped to save my life.
Thank you so much, Varsha. And you brought up so many important things that we need to discuss. I think a lot of people in the public think that when we talk about maternal mortality, we're talking about women dying in the hospital while they're giving birth. When in reality, the majority of deaths happen after delivery, up to 1 year postpartum, with the majority of those happening in the first 6 weeks. And if you think about the traditional way we have provided care, you deliver your baby, you go home, and then when do you see another provider? Not for 6 weeks. And clearly there's a lot happening between delivery and 6 weeks. And so we have to think about ways that we keep our moms connected to care during that time. And thank you for highlighting Connected Mom, because that is one way that we're able to make sure our patients are still being seen, but being seen in a way that's convenient to them. It is ridiculous to expect that a mom is going to come back into the clinic multiple times when she has just had a baby. And so I think programs that focus on bringing care to the mom instead of making the mom come into care are so crucial. And so Shelby, I'm going to turn to you now. So we've heard about Connected Mom and how it does that. And so I know you have a program called Family Connect that you can tell us about that does the free.
Absolutely. Thank you so much, everyone. Thank you, Dr. Keith. So I'm Shelby Wynne with Family Connect New Orleans, and we provide free nurse home visits to postpartum families that deliver at either Ochsner Baptist or Torrey. Exactly what you just said, that first 6-week period is the most high-risk period of the work for those postpartum moms. So our program, we focus on mom and baby. We like to say that we're the only visit where you get the whole family involved. Many visits focus on, you've had your kids visit for your child, then you've had your 6-week visit for mom. This visit is for everyone. And so as Varsha, you mentioned, hypertension and preeclampsia, they remain one of our most serious postpartum complications. And I pulled some data, because we love data. So over the past year, our family next nurses have identified 107 participants that had hypertension. That included 18 with preeclampsia, 8 with postpartum preeclampsia, and 12 with gestational hypertension. We like to say when our nurses go to the family home is that when they get these timely assessments and early assessments to make sure that these risks are not elevating and escalating, and we want the real goal to prevent readmission for our families and for our moms. We're working with Tulane currently to do our evaluation, and our evaluation shows that we have a lot of encouraging trends, so we'd love to hear that. So one of the trends is we have fewer hospital stays, so less readmissions, which we really appreciate. Lower Medicaid spending, which is always very important. And most significantly, we have a higher checkup rate. So for those that participate in that program, you're seeing about 84% completing that 6-week postpartum visit. And this is in comparison to about 70% of women that are not in the program. So we like to see that re-encouragement from our nurses to get our families back into care. Beyond the numbers, we love storytelling, and one of the most important things that our families are consistently saying at our program is that they feel heard, they feel cared for, and they feel reassured. When the nurses go to the family home, it can be family home or any other location of the family's choosing, we want to make sure that our families trust our nurses, because our nurses up at the community, they're all registered nurses, they all have either L&D experience or not baby experience. And what we're hearing is that all the nurses can be their best friends. And so when they do family home, it's just like another one of your girlfriends coming in to check on you. But these girlfriends also have the medical expertise to make sure that you're getting connected to the care that you deserve. Yeah. And again, within those 6 weeks, we really bridge that gap from discharge to follow-up. So we want to make sure their moms are connected and our babies are connected to make sure that they're thriving in the future of our city.
Thank you so much, Shelby. Let's turn to Dr. Williams now. So Dr. Williams, I think a lot of people in the general public and maybe even in healthcare think that one, delivery is a cure for preeclampsia, and they think that after 6 weeks that like we turn like we're pumpkins, like we go back into eat pumpkins and like until this focus has gone away. But that does not happen for all patients. So can you tell us a little bit about that, and especially in the cardiology world?
Absolutely. So I agree. So I like to think about it is that once a woman has preeclampsia, they will always have, some form of preeclampsia, meaning that the effects don't go away because you have baby. We know that when we look at women with a history of preeclampsia, we know that they have a higher risk of developing chronic high blood pressure, so use of, blood pressure medicines within 1 year of delivery. But even when we look out to 5 years to 10 years, there's a higher rate of development of cardiovascular disease. So heart failure, early onset coronary disease. So these are some of your women who are 35, 40 years old coming in with a heart attack without any otherwise risk factors. And so a lot of it has to do with events that occurred during pregnancy. So from a heart standpoint, pregnancy is like a stress test, okay? And if you have something go bad in pregnancy, you failed your stress test. And so, like any other stress test in cardiology, that means that you need to be seen, you need to be followed up, because something went wrong and it can impact your future health.
Thank you so much, Dr. Williams, and we'll come back to some of those more about cardiovascular conditions and future health. And again, looking at the data and reviewing the deaths, I unfortunately am seeing that quite a bit. So April, I'm going to turn to you, representing the AHA. What is the AHA doing to make sure that women, especially Black women, are aware of their risk of cardiovascular disease?
So thank you first for all of your testimony. I can relate. I will just say, as a mom of two, I also had the experience. I was optimal blood pressure until I gave birth, and then I had postpartum hypertension. And so I think about myself and I think about other mothers, especially Black mothers, having, number one, access to high quality healthcare. Also, the American Heart Association is very much focused on lifestyle and living healthy lifestyle. They're defining what it means to have a healthy lifestyle, but also thinking about what medications and what things can be provided in terms of policy. And that means looking at how we can effectively increase SNAP and increase access to WIC and increase paid family medical leave. And so we're thinking about policies, bold policies that are going to make sure that women and families really have an opportunity to take care of themselves and take care of their babies or postpartum. And then thinking about, again, the nutritious food. We're working on policies around food as medicine to make sure that there is access and that people know what they need to live a physically active life that ensures that their health is optimal.
So April, I want to come back to that because everybody in the audience may not understand that thread between nutrition and heart health. So I'm sure it has been said already at some point today, but just in case it has not, 80% of clinical outcomes are due to social factors. So that 20%, I can impact that by what I prescribe, what I do in the office. But patients leave my office and then they spend their life where they live, learn, work, play, where they have that environment that impacts their outcomes. And part of that is food, and like you said, food is medicine. So can you speak to that just a little bit more?
Sure. And so I think that everything is related to maternal health. I think increasing access to healthy food is maternal health. Increasing access to policies that allow for families to have a longer time for recovery after birth is a part of maternal health. But one of the things we work on through American Heart Association is an initiative called Food is Medicine. And really what that allows is for patients to have access, and not only access, but also education. So we're providing education to patients, or not to patients, but to community members, make sure that they know how to put together well-rounded meals, how to shop for themselves and how to prepare those foods for themselves as well. And so we have an initiative that's really focused on making sure that they have all of the resources in place to make sure that they can at least feed themselves well. And then we have programs that allow for them to really kind of build their own physical activity and that suits their lifestyles as well. So we have programs in place to help them do that as well.
And that's really good to hear for a lot of reasons. The new maternal mortality report for the state, which will be 2020 data through 2022, is scheduled to be released on Monday. And we find that in many of the deaths, pregnancy-related and those that are not pregnancy-related, that obesity is one of our biggest contributors. And so I think speaking to food as medicine and helping the community to understand that, when we talk about disparities as well, I just hope that everybody understands that race is not a biological condition. So the fact that we have a higher rate of deaths amongst Black women is not biological, it's social. And so it is things like having access and understanding the food and also exercise and how that impacts health outcomes and having access to healthy foods. And so for all the panelists, I want to ask you, and I'll start with Dr. Williams, that you said next to me. What does better heart health look like for you?
So better heart health to me starts, at an individual level. So we talk about prevention a lot. So that includes incorporating exercise on a regular basis. Also healthy diet, so focusing on what we would recommend in cardiology is a Mediterranean style diet. And we talked about this a little bit earlier today. Focusing on lean meats, veggies, complex carbohydrates, staying away from, the more processed foods, high foods and sugar. But then also, I think it's important in stress management. I think that plays a huge role, especially when we're talking about, maternal health and maternal mortality. And then oftentimes helping women to prioritize taking care of their health, because what I find is that they will often neglect their own health, for the sake of taking care of their family or just lifestyle in general. And so really helping them to find ways in their daily life where they can focus on themselves. It could be as simple as what I've recommended is that put your blood pressure cuffs by the toilet. I know it sounds weird, but you got to go to the bathroom, you're sitting down, take the blood pressure, finding ways to, put out your pills in a box and maybe put it in your purse, whatever works for them to just try to incorporate habits so that it's a lot easier for them to remember to take care of themselves.
Absolutely. So I wrote a little something. So Better Heart Health is more than just the numbers on a monitor. It's about the connection, the consistency, and the care that extends beyond the clinic, the social determinants of health. For me, Better Heart Health looks like a mom who understands her body, knows the warning signs, and has access to the support she needs to act early. Better Heart Health also looks like equity, where every woman, regardless of their zip code or their insurance, has the same chance to recover and thrive and be trusted with their families.
So I would like to just add on to what you all have already spoken about. I think that we have to broaden what healthcare looks like for what maternal healthcare looks like. And so one of those things, we talk about the social supports. We're talking about the cardiovascular screenings. I think we have to really increase cardiovascular screenings. Nutrition, talked about nutrition, mental health. I think is really important. And then I am biased. I work in advocacy, and so I really think about policy change and what that looks like. So I talked a little bit about increasing access to or extending coverage for Medicaid for 12 months so that we are covering the woman postpartum. I think is extremely important. I think advocating for also building clinician capacity and cultural competence. And so that we know that we are supporting communities effectively, regardless of their race. I think I talked about expanding staff. One of the things that we have not necessarily talked about is investing in affordable and accessible childcare. And so that's something that we are working on at American Heart Association through our work with the National Collaborative for Infants and Toddlers. And so how do we make sure that parents have those types of supports in place? And that is to reduce stress and to also help with the mental health of the parents and the mothers.
Before we go into you, Varsha, just want to pull up, because I'm all about the advocacy part. So I was pulling a couple strings. I will say, because I've said a lot of bad stuff about stats for Louisiana, we were the first state to accept the CMS waivers to make sure that our moms had Medicaid extended to 1 year postpartum. So I think that is something to be applauded, because we're not first in a lot of the things that we were there. So I think that definitely is to be applauded. And definitely we have got to work on not only childcare access, but we are the only country that does not guarantee that a mom has at least one visit in the postpartum period, the only high-income country that doesn't. That's why I'm really grateful to partner with Family Connects, because they are making that happen. We are also the only high-income country that does not have guaranteed paid family medical leave. And so we haven't really talked about that much, but we have talked about how the postpartum period, it's truly the most vulnerable period when we're talking about maternal mortality. And there are a lot of moms that are back at work because they don't have any other, that's their only source of income. So there is a lot that we need to do from a systemic standpoint, and that happens through policy. So Varsha, what does heart health look like to you?
Yeah, so from a patient perspective, I would say empowering self-monitoring, making sure that moms track their health, know the importance of why they're doing it, know those important signs for blood pressure, swelling, shortness of breath, those kinds of things, empowering the self-care. And we live in a digital world, and like you were saying, it's hard for a working mom who's just had a baby to make those appointments. Transportation is hard. Finding childcare to go to the appointment, because you're going to take an hour off of work to go to the appointment, to then sit in the waiting room and wait. And so that's 2-3 hours that you've missed from work. That's having like digital visits, Zoom visits, and of course, the digital monitoring after pregnancy is super important, and ensuring that patients and their providers have that relationship where you can trust your provider. Like for me with Dr. Gillispie, I trust her. I know that, she really cared about my well-being. And so when you trust your provider, you'll listen to, what they have to say. And so when she was telling me, hey, when you go home, I still want you to monitor your blood pressure, that is important for me to continue to follow. So in improving, digital monitoring and Zoom visits for patients, I think is super important, so that patients are compliant with what our physicians and what our providers are telling us.
And just to talk about digital medicine, this isn't June's class for me. To talk about digital medicine a little bit more, we talked about the connected mom and the blood pressure aspect, but I don't know if you would like to share, or you want me to share what happened with Hurricane Ida. So I practice at Kenner, and so when Hurricane Ida hit, like we had to evacuate, everybody was evacuated. And so I was on the phone, I called Varsha, I was like, I know you're pregnant, I don't know where you are right now, I'm in Florida, can you hop on this visit at 1 o'clock, take your blood pressure before, and hop on a visit at 1. And so it was a way for us to make sure that our patients were still connected to care, even in the middle of a disaster.
Absolutely, yeah.
And I think part of that also goes into that trust part.
Absolutely.
Okay, can I get the time check before I start? I was going to open it up to the audience, but I'm not sure. Okay, and are there any questions from the audience? Yes.
Okay. This is going to be more towards the whole day. I know you got on maternal health, but throughout the day, there's been all these statistics. We talked about 80% of your obese, about 80% of this. We learned about care teams from the other group. We learned about a connect team. Those two things seem like they could be replicable throughout the state, but there's no momentum there. What we share on the statistics upon lag, it's a lot of outcome lag measures. What need measures are we putting in place or can put in place that we can actually know that the trajectory is going to change?
I think that's a great question. I'll answer it from the maternal health side, but I don't know if that's going to be, it's probably going to be the same if we're not talking about maternal health. You're right, that going back to the data, there's a lot of lag on the data, even when we look at severe maternal morbidity, which we're talking about mortality, but for every case of a death, there's 70 to 80 cases of severe maternal morbidity. But there's even lag with that, because of that data coming from hospital discharge data. And with the maternal mortality review, because the definition of a pregnancy-associated death is a death of an individual at the time of pregnancy up to 1 year of the end of pregnancy, that means we have to wait a whole year from the birth to determine if the death happened. So that again causes a lag, plus the process of reviewing. What I can say that's happening on the maternal side, so as again, from the Louisiana Perinatal Quality Collaborative, or LAPQC, we partner with our birthing facilities to implement evidence-based practices. The outcome measures may be a lag because it's discharge data from the hospital, but process measures and structure measures can be done in real time. So we do have our hospitals reporting to us on process measures. So for example, when we're working on reducing severe maternal morbidity from hypertension, one of those process measures are the patients that are coming in that have signs of severe hypertension, are they getting diagnosed at the right amount of time, and are they getting treated in the 60 minutes from initial presentation, which is the recommendation. Because we are a perinatal quality collaborative, what we work on is rapid data so that we can work on improvement. And so we take that data, we feed it back, the hospitals feed it to us, and then we meet with them on a quarterly basis, officially, but we are really talking to them on a weekly basis, to say, this is what your data is showing. You're not doing X, Y, and Z, and that's going to result in this outcome. So there are efforts that are happening around that. As far as the care coordination and the coordination, this is, hopefully not getting in trouble. So from the coordination standpoint, we have advocated, I would say a lot on the mortality review side of using Medicaid as a system to help to coordinate, because 62% of our births in Louisiana, and maybe up to 64% now, are covered by Medicaid. So that means that that is a coordinating system. And Medicaid or managed care organizations have care coordinators. So we are working at least on the state side through our managed care incentive program and the managed care organization withhold program to create measures and metrics so that we are having a systemic approach. I helped to lead a work group for the maternal health measures. So we do have measures in there like care coordination, and not just do you have care coordination, but how many patients that meet this criteria are actually receiving the care coordination. How many of your patients are actually, there's a CMS measure for screening for cardiovascular risk. How many of your patients are being screened for this? And so I think we have to look on a larger systemic level. What is the connecting system that we can use to leverage to do some of that work that you're saying? Sorry, it's a very long answer. Sure. Yeah.
So all throughout there as well as in the nutrition part, is there any way for us to have information on what's being sold through the stores or through the restaurants that people are digesting that give us a foreign advanced need measure stuff's coming off the shelf that we know that everybody's saying it's not the best nutrition, that you could be talking to the state level as well. Not that we can change people's habits, but if we know nutrition-wise things are not moving in the right or they're moving in the wrong direction.
Yeah, I think that's an amazing suggestion. We do have under the chronic disease work group for those MSIP and MCO measures that I was talking about, they do have a food as medicine measure in there. So there will be efforts for the managed care organizations and the hospitals participating in MSIP to work on that food as medicine and giving prescriptions for better foods. Now, I don't know that we have the authority I think that may be federal to know what is actually in the food that you purchase at fast food and stuff like that. But I do think we can at least help our patients to understand what is healthy food, how do you get healthy food. I think the biggest thing I hear from my patients is just the time and the access. I have access, and it would be much easier for me to run to Chick-fil-A than to come home and cook. And so trying to help our patients to understand how they can have access to healthy food, it still be timely, still be efficient, and also if you are going to choose, if you have to access fast food or what is a healthy choice there. And then if I don't know if you have any more to add because of what y'all are doing with it.
Yeah, I was thinking eat this, not that. I think that we have our own guidelines, and I don't have any physical resources, but at heart.org you can find those guidelines. We also provide those things, healthy recipes, guidelines. We do have some information about processed foods and those things that you can look at, those resources on our website. And I'm sure we can get those resources, physical resources to whomever is interested.
And some of those resources exist through EatFit and Ochsner as well about how to relabel.
We're partnered with everyone.
Yeah, exactly. So yeah.
Why does the have bank that you love right now?
There, if I can, over here. That voice me morning. I want to tap into a question earlier and also kind of wrap up, connect a lot of conversations that were had in the first and the second panel to this panel. One, just for clarification, because I know that a lot of people in the room are not with the healthcare organization. So CMS is the Center for Medicare and Medicaid Services. So I know we've used that a couple of times. One thing in terms of the rural health issue, and we talked about the districts from hospitals, lack of timely access, question about how to leverage technology for the sake of improving access in those situations. Recently with the Big Beautiful Bill, let's call it, there was a specification that I would say was largely driven by the Louisiana representatives or congressmen that added provision around $50 million per state to apply for innovation using technology to improve health for the rural hospitals. Because if you remember in the debate, there was a lot about how the Medicaid cuts were going to impact the rural parts of the state. And in this case, for us, largely North Louisiana was going to be massively impacted by these cuts. And so it was actually our senators who got it included into the bill. And Louisiana, the Louisiana Department of Health did submit something as an application. I have no clue what it was. I do know that they were soliciting information from Ochsner and others around ideas for using technology to improve access to health. So let's stay tuned for that to see what Louisiana is planning to do once they get ready related to that. So that's one thing. But something that is often not paid attention to is this access to even using your cell phone when you live in rural parts of the state where the service drop, right? So we have broadband issues and other things. So even if we have the technology, if you are living in a place where you can't connect with your cell phone, you're still going to have some challenges. And so making sure that from an advocacy standpoint, we stay on top of making sure people can connect to the internet through whatever means is an important thing to keep in mind as we talked about earlier around advocacy, and in this case specifically around technology to improve access. I mean, that's something that we impact, although it's hard to impact physical location of hospitals and stuff like that. So just wanted to point that out and make sure that everyone pays attention to whatever comes out of the pipeline related to these congressional legislation that we've been watching in the news.
No, that's a great point. And under the previous administration, I worked with the FCC to label broadband as another social determinant of health. And they created they have a map for chronic conditions, but they also have a maternal health map that you can overlay broadband access and severe maternal morbidity. So the places that have the least access have higher rates of morbidity. They have higher rates of substance use disorder, higher rates of hypertension, higher rates of diabetes. So I think that's a great point. We have to continue to advocate for broadband for everyone.
I think it'll go. Okay, you guys can hear me. Lord Coleman, I want to ask you all, I've been hearing a lot about medical misdrugs with how it starts in the individual and advocacy, and also how you can use technology to leverage as far as cardiovascular disease within maternal health. But looking at 2025, I'd like to know how you see doulas, midwives, and community health partners fitting into cardiovascular conversation forward.
So I'll take that question because I think it's an excellent question. But they're key players. And I want to highlight that the AHA also has a maternal health equity and research network. I'm on the oversight committee. And a lot of the research projects that are currently ongoing are looking at how do we partner with community workers, midwives, doulas, community health centers in order to capture people that are at high risk or have more difficult access to care, whether that's location or other things that are going on. And so it's extremely important because those people are on the ground and they have more intimate contact, I would say, with patients, and also more frequent contact. So there are multiple opportunities to touch and to educate, and also, if needed, to get those patients into care. So they also serve as advocates as well. So they are able to identify issues and say, you need to be seen here. So I think that they are essential when it comes to talking about maternal mortality.
I agree, and just for visibility, I worked with some maternal health advocates, and doulas are now covered in Louisiana under Medicaid and private insurance. The way we did the bill, we did it as a two-part bill, similar to what was done in Virginia, where we first created a doula registry, and then the legislation that anybody in the registry is then covered through private and covered through Medicaid. And the registry has been established and started accepting applications for doulas in January, and so now there are 175 doulas are in there. So they are covered by insurance, and that was important for us to make sure all the data shows that having a doula involved in your care improves your outcomes. And so this was a movement to make sure that everybody has access to doulas.
And I'll just add to that, since we started talking about that, I think what's important from a policy perspective and the systems perspective is to increase that doula coverage across the country. So looking at other states, making sure that doulas are reimbursed for their service as well, and kind of build some standardization around how they are compensated as well, and are effectively fitting into that care team. Any other questions?
Relationship between the package both part of does the drug and art or the paramed water or
Yes, there is a very strong connection. So anyone that has an adverse pregnancy outcome, whether that's high blood pressure during pregnancy, so preeclampsia, gestational hypertension, or gestational high blood pressure, even preterm deliveries, stillbirth deliveries, diabetes, we see increased risk of those outcomes, 5-10 years down the line. So there is a very strong connection, and part of our work in cardiology is, as well as OB-GYN and MFM, is identifying those women, when they deliver, because those women really need to be educated, and they really need to be screened and treated aggressively at younger ages in order to try to reduce their future risk of cardiovascular disease. And it can be hard in a population, especially younger women, because oftentimes, they feel fine. And it's not until something happens that, we realize that, there have been underlying problems that have been going on and may not have been treated.
The one thing I haven't heard mentioned is GLP-1s. That how do they protect the heart and prevent obesity?
Take that question again. So GLP-1s are great medications, and so they work in multiple ways, but one of the things that we do know is that not only does it improve glucose tolerance and metabolism, but it also helps in what we see as other surrogate markers of cardiovascular disease. So weight loss, improvement in blood pressure, improvement in your cholesterol, and then depending on the underlying disease, also improvement in patients who've had, heart failure, heart attacks, and strokes. And so because of that reason, we are using them a lot more. There's still some work on, from a policy standpoint, because all patients, insurance will not cover them. Mm-hmm. So they have to have certain diagnoses in order to get the medications covered. But I do think that for patients who can take the medication, that it's important that we treat them. That goes in treating, the whole patient, because we can prescribe a GLP-1 agent, and let's say the patient loses, 50 to 100 pounds. Well, we just improve their blood pressure, we just drop their cholesterol, we improve the control of their diabetes, and so we're talking about significant prevention for future cardiovascular disease.
Any other questions? One more thing for advocacy. To advocate for. That's all. It's also a recommendation in our panel report. Before the GLP-1s were a thing, it was a recommendation in our panel report because we saw how much obesity was contributing to maternal mortality. But we also know that, again, 62% of the births covered by Medicaid, that most of those patients were not eligible for any weight loss medication, weight loss programs, and so we have been pushing for that as well.
At patient timing now about you, I know about their timing. Listen.
That's a loaded question. That's a loaded question. So that's a great question. And I always, one of the things that I will say is that most drugs, even though there are potential side effects, in order for the drug to make it to the market and become, mass distribution, we have to make sure that it's safe. Okay, so if anything is deemed not safe, meaning that the risk of the drug outweighs the benefit, then the drug is not released. And so for some patients, I will often tell the patients that it can come down to a risk versus benefit discussion. So for most of our medications, I will say that the likelihood of developing something severe is very low. But let's say that there is a medication, and we can even talk about it when it comes to chemotherapy, where there is potential side effects that could be life-threatening. Sometimes we have to weigh, the risk of not treating something and what that can mean versus the risk of taking the medication and getting better. And so I like to frame it as like, this is a medication to help us to get to the next step. So it doesn't necessarily mean that you're going to be on this medication forever, but maybe we need some help to lose weight, to improve these other things. And then once we get to that goal, we can start to, scale back on medication. So I think it's a valid question that a lot of patients do have concerns about the long-term effects. But I will say that as a medical community, we really do our diligence when it comes to medications to make sure that they are safe. And if a drug turns out to not be safe, then it's removed from the market.
All right, any last parting questions before we wrap it up?
All right, I'd like to thank my panelists. Y'all were all amazing. If y'all could please give them a hand. And thank you all for being engaged and hanging out with us on a Saturday. Thank you all.